think the best way for patients to be prepared for their first initial consult with an oncologist is, one, to come with a carer or a support person, because 2 pairs of ears are always better than 1, and then make a list of questions. Things like, what cancer do I have? What stage is the cancer? What are my treatment options? What if I choose not to have treatment? What are the advantages of treatment? And what are the potential side effects of that treatment? Or if I choose just to have surveillance, what does that look like? You know, is that coming in and seeing the oncologist every 3 months? Is it having scans? Does it require blood tests? Not all the questions will be answered in this initial consultation. Sometimes it's just an introduction about formulating a plan or organising some further testing and coming back to formulate that plan. So don't be too distressed if you go in the first time and leave not 100% sure on something. There's usually a cancer specialist nurse or a cancer nurse coordinator that you can contact to clarify that information. Or alternatively, you could request to have another consultation with the specialist prior to starting treatment if you are unsure of a plan. Patients can find out their treatment plan when they come and see the oncologist for the first time. And sometimes that plan's not always clear. Some patients' cases are discussed at what we call a multidisciplinary team meeting before confirming the management plan. And that involves a group of radiation oncologists, medical oncologists who do the chemotherapy, surgeons, pathologists, radiologists, and allied health and cancer specialist nurses. So sometimes you may go and the plan is not firm until your case has been discussed in a multidisciplinary team meeting. You should be informed that your case is going to be discussed and informed of the outcome. Initially, some patients come through seeing their surgeon first, and the surgeon will give a rough outline of what that plan may be for the patient. But at times, those plans changed and they're not standard like everyone else's, they're individual for the patient's needs. The first place to start inquiring about a clinical trial is through your medical oncologist. They are up with current trials that are available for your specific cancer or have the resources to find out the information. Alternatively, you can do your own research. There is the Australian Clinical Trials Registry, the Australian New Zealand Clinical Trials Registry, or alternatively, the GI Cancer Institute. And that is www.gicancer.org.au. They are currently running several clinical trials. It's worth having a look and seeing if there's something suitable for you. If you find something that you feel that is specific to your cancer, then discuss this with your treating doctor. They will then refer you to that centre if appropriate. So case managers can be cancer specialist nurses. In other centres, they're called nurse navigators or they're called nurse coordinators. And they are involved with patients' care and can be there as a resource for patients to find out information, to help clarify their plan that they're having. Some can attend clinic appointments with patients to give that extra support. They can be a contact for patients that are in the community when they're undergoing treatment for assistance with symptom management, or facilitate referrals to other centres if needed. Not all centres have cancer nurse coordinators. I'm fortunate where I am, and we have individual first tumour specific cancers. Other centres, there are cancer coordinators that do a variety of tumour groups at once. The best thing to do would be to ask your oncologist who you are seeing for the first time, or maybe your surgeon, or you could ask an administrative staff member when you enter into a cancer centre, is there cancer specialist nurses or nurse navigators or cancer coordinators in that centre that can assist you? The best place to start with and the easiest is to obtain your own diary and start writing down some details when you have some side effects, and also how you have managed those side effects. So then when you come to a consultation with an oncologist, you can actually quite clearly communicate with them the side effects that you've had and what you've done, whether those you've managed those side effects well, or whether there's something else that they can do to improve them. There are several apps out there as well that you could actually download onto your phone that allows you to put that information into that type of tool. Other than that, some of the medications that are given actually come with booklets that you can fill the information into that show the side effects and what to do with them. In some centres, there are social workers, counsellors and psychologists there available that can see patients on the day of treatment, or there is a community referral basis for patients to be referred to the community to engage in that psychological support. If there is none available for you in the centre that you're at, you can actually see your GP and get what is called a mental health care plan, and then you can be referred to a psychologist in the community, and that mental health care plan goes towards the cost of that. Otherwise, you can engage in a private psychologist for some psychological support. Support for patients that are from a non-English speaking background, if you're coming actually into a cancer centre, you can access the translation service. So if you've got a doctor's appointment and you've got a family member that English is second language and you are actually interpreting for them, this can sometimes be met with challenges in translating that medical information. So it's best to access the translation service, which can be done by telephone. You just call. It's organised through the hospital. You can ask the hospital to organise it. So when you're in a clinic appointment, you have someone translating via the telephone that conversation with a medical oncologist or another specialist. Within the hospital, we also have Aboriginal liaison officers, which I think are in most large centres. And they are there for our Indigenous Australians to be able to speak with someone that understands what they may be going through, or to be able to help them understand what's happening, and also the greater community. So then when they're discharged from hospital, it's the role of the ALO to make sure that the patients are supported in their community. Or if they have family members that are in regional Australia, being able to help the family members communicate with them. Always ask your treating specialist if you're needing that extra support, where you can find it. There is a lot of information on the internet for your Indigenous Australians around cancer, and some booklets and information for them, which gives nice, clear information. So if you ask, then you can be guided to that literature. There is some documentation or booklets that are in other languages through the Cancer Council, and also some information on the New South Wales Cancer Institute site, EverQ, in different languages, but it's limited. So just ask if you're wanting some further information in a different language or for a different culture. Patients that have been coming into the cancer centre for a while and have had surveillance post-finishing, say, adjuvant treatment after surgery, which means you've had chemotherapy originally after your surgery to prevent the risk of cancer returning. And if you find later on, a number of years down the track, that you'll then have metastatic disease or recurrence of disease, it's very confronting, because this is a different situation. This means that you have a terminal illness. It brings about all the questions about quality of life. Should you continue and have further chemotherapy? Are you better off not having chemotherapy? You've got the side effects of chemo, and then the side effects of the cancer. The chemo will alleviate the symptoms of the cancer, but bring you the side effects of the chemotherapy. So it can be a difficult decision for patients to make. And each cancer, GI cancer, is different depending on metastatic disease, survival outcomes. So this is a very difficult decision for some patients to make, when maybe you may only gain another 6 to 12 months life from embarking on this chemotherapy, and then you've got the side effects of chemotherapy. The other conversations that we need to have with patients when they're diagnosed with a terminal illness or metastatic disease is things around, have they got their will? Do they have an enduring power of attorney? Do they have an advanced care plan that can be given to the hospital? Do they know what they want for their future? Some of these conversations can be done through the palliative care team. And at some point, patients with metastatic disease will be referred to the palliative care team if there one is available in your community. The palliative care team can help you with these conversations about, do you want to continue with treatment if you're finding that you're spending a lot of time in bed? They can help with symptom management, so pain and nausea. They talk to you about what your plan is for end-of-life care. Is that to be at home with your family? Is that to be in a hospice if the hospice is available? Or is your wish to die in hospital? Those conversations are ongoing. They're not a conversation that happens once. They change with a patient's pathway. Some patients can live with metastatic disease for 3 years. So what they may think they may choose in the beginning is very different 3 years later down the track. The benefits of having open conversations early is that everyone in the family knows what's happening and what your wishes are. If you have children, communicating with the children in different ways. Some people will tell their children up front. Some will like to wait, and everybody is different, and this can be difficult. So talking with the palliative care social worker or their counselling service can actually help with you make some of these difficult decisions. The most important thing is patients are supported through this time and are able to be empowered to make their own decisions about their cancer pathway and what their wishes are. Some patients choose not to have any treatment, and for family members that can be very difficult to understand, when this can mean that they may live for several years if they choose to have treatment. But in the end, it's the patient's decision. They need to be supported by their family if they can be, or by the medical profession. And us cancer specialist nurses are there to advocate for patients and to support what they feel is the best treatment pathway for them.